Ladies and gentlemen, it's a pleasure to be with you and to try and give you some of my experience through Dental XP. I would really like to grab the chance to thank the group of Dental XP, especially Eddie, who I really appreciate what he's doing to this group. As you know, Dental XP now is an educational organization. I really watch it lots of times, and for this presentation I would really try to give you some clinical tips for your everyday practice. This part will pave the way to reach simplicity in working with implants. I will try to show you how I think and what I reached through the years. My name is Professor Mohammed Shireen El Attar. I used to be the ex-dean of the Faculty of Dentistry, Faros University in Alexandria, Egypt. Currently, I am a professor of prosthodontics, Faculty of Dentistry, Alexandria University in Egypt. I was appointed as an associate professor of prosthodontics, School of Dental Medicine, University of Pittsburgh in USA. I was the founder, president of the Alexandria Oral Implantology Association, called the AOIA, and I was appointed as an ambassador of the International Congress of Oral Implantologists in USA, the ICOI. However, with all the previous titles, what I love is this title, a treatment planner and a clinician. For a PhD holder, in the context of academic degrees, the term philosophical doctor does not refer solely to the field of philosophy, but is used in a broader sense in accordance with its original Greek meaning, the love of wisdom. That's going to be the theme of my presentation, some points that you would definitely like. Here is the theme of our association, is let's give it a try working together. We work as a team, everybody is helping. In big cases, several of us are working together. And it was an honor to be appointed as an ambassador with the ICOI. This puts some responsibilities concerning education around the world, and especially in the Middle East. In May 9 to 11, 2012, we had our second STARS meeting. In March 24, 2010, we had our first STARS meeting. By the way, in both congresses, which are now a well-known event around the Middle East and maybe the world, at the first one we had Dr. Henry Salama, a part of Team Atlanta, and because of the amount of success we had with him, then we invited both of them, himself and Maurice Salama, to be our keynote speakers in the second STARS meeting. It was a pleasure, and I really appreciate what they're doing. They're brothers, but they're doing great work. It's great to be involved with implants, but it's really marvelous to have an ongoing effect on the international level of treatment with implants. And by the way, when you watch this word, ongoing, it reminds me of what I'm going to talk about in those two parts, especially when you would know that what was called the temporary implant in the past turned into what's called the ongoing implant, then to a permanent narrow diameter implant. At that time, when I learned to work with implants, this is the way I used to look like. Then went back to Egypt, and working with implants was a big responsibility, but nowadays everybody is working with implants, and I'm so happy about this. That's when I decided to remove my hair and have a new way of looking at implants. Let's look at life from a dental point of view. Being single, at the beginning, usually we need a single toothbrush. Then we get married, and please notice the two toothbrushes. Then we get kids, and that's when we have lots of toothbrushes. Then kids are married, and we are left alone. Then one partner is widowed, and then no brushes needed. But that's why we are here. Let's go into business and start our way through what I'm going to talk about. In October 1999, we had a marvelous article published in the Journal of Implant Dentistry. It was talking about temporary implants. And if you would watch here, you would find a regular case of implant over denture where implants would be placed on the both cuspid areas. However, at that time, patients would go home with no dentures, and they would be instructed to eat soft food, and maybe the dentures would be relined by tissue conditioning materials, and it was suffering. At that time, we found something that was called temporary implants that I really appreciated at that time, and started using them in implant over denture cases for the patients to go home and use the dentures immediately. At that time, those temporary implants used to cost like $20 an implant, and it was this radiographic photo that I inspired this article from, where this clinician used temporary implants beside permanent implants to put temporary bridges for the patient to go home and use them immediately. This was a start of the idea of immediate loading. Those temporary implants were 1.8 millimeters wide. The diameter was 1.8 millimeter with different lengths. They were highly polished, no flutes, no notches, nothing. Started to use those temporary implants in lots of cases, and I love this photo because it shows 3 temporary implants combined with the permanent implants. At that time, everybody expected that those temporary implants would fail. However, due to rigidity, or let's say osseointegration, in order for me to remove them, it took lots of forces, and at that time, if I knew how much osseointegrated they were, I would have left them to be incorporated with the final bridge. Of course, on the top left, you can see a lousy temporary bridge. This bridge stayed in the patient's mouth not less than 6 months, and this patient had terrible oral hygiene. However, the implants were really in place, and you can see them on the top right with lots of debris, however, still very solid in the bone. At that time, I started to use those implants in most of my cases, as you can see, and in this special case, the final bridge included both the permanent implants and the temporary implants. And then it became a routine, even in distal extension cases. You would place an implant or a couple of implants and add the temporary implant in order for the patient to go home and use this side immediately. Patients did not have to wait for the osseointegration or healing period at that time, and it only proved success of those temporary highly polished implants. So, when we look, what do we need in a definitive implant? Number one, a rough surface, which would be 6 times greater than smooth surfaces. Flutes. At the beginning, they thought it was an anti-rotational component. However, this proved to be nonsense. It's only a bone storage area while you are threading the implant. 3, tapered apices and body to need minimal drilling. And of course, this is to reduce the amount of heat while you are drilling for an implant or osteotomy. And it should allow for both immediate or delayed loading, and it should have the ability to provide an adequate soft tissue volume. And you know that around the world now, everybody's talking about soft tissue, and you need lots of soft tissue. Another thing that happened with me was this article published in the Journal of Implant Dentistry, March 2006. It was titled, "Early Osteotomy with Delayed Implant Placement, a Step Further for Immediate Loading." That is published in Implant Dentistry, as I said, March 2006. In the year 2012, I was called to explain what's going on with this idea. And you know, as an author, you always wait for criticism after you publish anything. This special article, nothing happened after it was published by at least 2 years. And then everybody started talking about it and thinking about the idea, with the success of what's called immediate implant placement after you remove natural teeth and placing implants immediately. Then in this year, 2012, there is an article published in the Journal of Oral Implantology with the same idea, referring to our idea in the year 2006. I will explain the idea, okay, and it only talks about what happens when you drill bone, and found a classical article published by Perron, 1972, explaining simply what happens when you drill bone. Inflammation happens immediately. A couple of weeks later, there's the connective tissue phase, and a couple of weeks more than bone formation. That's why simply when you talk about what happens, people would always talk about the 4 weeks situation, because inflammation happens, and then 2 weeks connective tissue, then 2 weeks bone. So the idea is to open a flap and drill, okay? And let's give an example by this case. Of course, as a surgeon, you would love to have a flap, because it makes you see and feel where you are going in order to prevent any sort of perforation. Then you open the flap and you drill wherever you want to place implants, and then you close the flap, placing nothing. 2 weeks later, which, as I said, would be the connective tissue phase, which has revascularization and the start of healing, then you use the punch, and the punch allows you to dictate the cervical height of the restorations. And from a prosthodontic and periodontal point of view, a punch is a magnificent tool. Then you start placing your implants after some curettage and irrigation, no drilling. You place the implants, and in this special case, you see that we had to use an angulated abutment in the upper lateral incisor area. Then you can place your temporary restoration immediately, and the patient would go on using this for 3 months, and then you can restore it in a final way. Moreover, I had a publication, like a chapter author in the Dental Implantation and Technology textbook that was published in USA in 2009, also talking about placing and loading implants. My very nice thing to do was this book that was published in USA June 2012, and I really push you all, or advise you all, to buy it through the net in Amazon, Barnes & Noble, and everywhere, because it's directed towards younger generations from around the world, and maybe even middle-aged dentists who would probably benefit from some of my ideas that I gained through the years. Let's talk about part 1 and send messages to dentists and implantologists. In the year 2006, in the Journal of Implant Dentistry, Dr. Morton Perel had this editorial which really had lots of meaning. Endodontics or implants? Is it that simple? And if you look about what he's saying as a conclusion, ultimately it all boils down to how to best serve the patient for that given case, for that given situation. Will the anticipated best result emanate from an endodontic procedure or an implant procedure? And who has the ability or training to perform either? This, at the year 2006, is really something to stop and wonder about. Because as you all hear, lots of dentists, they would feel it's very easy, just remove the tooth and place an implant and that's the end of it. Of course, lots of dentists around the world are against this idea, and you should do your best to save natural teeth. Then came Dr. Stephen Eckert, who is the editor-in-chief in the International Journal of Oral Maxillofacial Implants in 2008, asking about implants. Is it becoming a boutique practice? And let me stop here and really discuss this issue, because if we are going to consider implants as something only for aesthetics, okay, then we are really forgetting more than 90% of the people around the world, okay? Because from my point of view, implants is a tool that makes people enjoy life again. So if we all have Julia Roberts as our patients, then this would be okay to think of implants as like a boutique practice, but no, lots and lots of people of the world population need implants to really enjoy life again. Then came Dr. Michael Picos in the year 2009, and he was talking about the unhealthy competition and how dentists and programs, graduate programs around the world are forgetting about real dentistry, and they are concentrating on implants. Even the treatment planning, even the base or the advanced therapy of perio and prostho and surgery, they forget, and endodontics, of course, they forget about it, and they insist to concentrate on implants, and I don't think this is healthy. We should really concentrate on dentistry. From my point of view, people would fall in pitfalls. Let's look at the forest while they look at the trees. What I mean here by the forest is the human being, the patient. However, we sometimes just deal with a space, for example, that we should put implant without looking to the whole mouth condition, and that putting an implant in a case like this would be a big mistake, and treatment would have really been done in a better and simpler way without implants. The forest, as I said, is the human being. We should really concentrate and ask about the general state of health, psychological state, and the patient desires. And especially at this part of the patient desires, I think lots of people do not listen. They don't listen. They don't know why the patient is coming to you. And you should listen and know what does this patient really need. How to check the forest? We really need minimally panoramic radiograph and listening to the patient. And a first clinical tip is examination of the mouth should be quick, because if you really know how to diagnose from panoramic radiographs, then you have a big idea about what's going on inside the mouth. I really like Larry King, who used to work with CNN, and he said, I discovered something I never learned when I was talking. And I like what he said very much, because if the dentist starts talking and talking and talking to the patient, then he misses a lot from what the patient has to do. A tree in the forest is the tooth. It's only a tiny part of the forest. if we concentrate on one tree in a sick forest, we actually did nothing. So, do we really know what's the right way and time for using implants? Is it a limited treatment tool? The implant way of thinking is now leading for more than 2 or maybe many decades. Maybe it's time to stop and think in a human dental way. Let's start by the symphysis area. With all the diagnostic instruments that are starting to be common around the world, like CBCT and things like that, I think, and if you wonder with some articles that have been published lately in the implant journals, you would be shocked, because everybody, when you're starting to teach someone to work with implants, then you advise him or her to work in the symphysis area. Last couple of years, there was this article in the Journal of Implant Dentistry talking about a very special case. While the dentist placed a couple of implants in the symphysis area, knowing, of course, that it's the safest area in the mouth, or at least that's the way we used to feel. And then, during the loading stage, something happened that caused a big hematoma to start forming, and the patient was going to die. But thank God he was able to transfer her to a hospital for life-saving, and everything went okay. However, the arrows here would show the branches of the sublingual artery that were touched by the implants. And this was again published in the year 2012 in August, Journal of Implant Dentistry, talking about the mandibular incisive canal and branches of the sublingual artery in the symphysis area. So please take care that it's not as safe as everybody used to believe. Let's discuss some cases, please. My question on the top is, why implants there and what type? Of course, if we go to the left photo and we see there's an implant in the upper left lateral incisor area and the upper left first bicuspid area. Looking at the whole mouth and the neighboring teeth, please tell me, why would I place an implant on the maxilla on the upper left side? I don't see any reason. If it was up to me, I would do a straightforward bridge. Or at least I would have placed the implants on the mandible, where the patient really needed it. The right photo, if you look, very strange implant crown ratio. Of course, I know that implants would take more loads than natural teeth. Of course, you know that because they are osseointegrated. However, what happened was, with the 3 broken implants, that the screws were broken inside, and the patient had to have a maxillary implant over denture to solve the problem. Please look at the bottom, at the mandible in this right photo, and see that lousy bridge. Would you believe that this bridge lasted this patient for 12 years? And then I had to replace it, but only for aesthetic reasons. Can you believe this? This bridge was successful and the implants failed. The question comes, well, we go back to the left photo and we ask, what type of implants are those implants? Patient comes and wants the case to be completed in your office, and you have no idea what type of implants are those implants. What are you going to do? Are you going to start trying to place screwdrivers and abutments till you reach a suitable one? No. It's our responsibility to give our patients all the data after placing implants. Maybe the patient is going to travel, or something would happen that would prevent you from completing the case. So it's a must, and it's ethical to give your patient full details like stickers or written information about the implants used. Please look with me at this implant on the upper lateral incisor region. Why? The neighboring teeth are all caries or restored with restorative filling materials. Why wouldn't we do a bridge? And by the way, why this length of implants? I remember the longest implant I placed in my life was 21 millimeters long. At that time, I was so happy and proud by placing this long implant. But nowadays, I know better. We don't need long implants. Maybe at least not more than 14 or 15 millimeters would do the job, because as we mentioned previously, an implant is also integrated and you can compare an implant with an ankylosed tooth. Same thing, why would you place an implant on the upper right bicuspid area? I see no reason. Placing this implant in the sinus area and having a sinus lift operation done here. Why? If you have done a bridge with one cantilever, I think it would have done a great job to this patient. Here on the right side, you can see the case where 3 single crowns are placed. One of them in the first molar area, and I see no reason for this. If we did a straightforward bridge, this would have done the job and preserved bone, and the patient would be happy without any risk of interfering with the sinus. On the left side, you find many implants with a temporary porcelain fused to metal bridge. Then the patient comes to me telling me, I had big problems with my dentist and I want you to complete the case. Started to try and know what type of implants were these, but was unsuccessful. Of course, this is not okay. I had to send the patient back to her dentist. I refused completely to go ahead with the case. Let's look at a case with real details. This was a case that was done a couple of years ago. The case came to me like this. Of course, you can see very nice porcelain or ceramic work. However, some gingivitis, and I want you to concentrate with me because we are going to start some very important clinical information here. I would have loved to be the prosthodontist who did this. However, the case came to me for another reason, and I'm going to explain. It all depends how you see yourself. Okay? Let's look at her panoramic X-ray, okay, and see what's going on. On the top left, you can see this was published June 2012, Journal of Implant Dentistry, and I really urge you all, when you look at a panoramic X-ray or radiograph, that you routinely would check the nose or the nasal area. Because what happened was that in Alexandria, about 5 years ago, we started following cases which had turbinate or conchi enlargements. And we found out that those enlarged conchi would cause what's called the silent trip, or postnasal discharge that would go directly to the gastrointestinal tract and would cause stomach irritation and maybe intestine irritation, and then this would cause again the saliva to have a very awkward pH values, and that would cause caries, lots of caries or decay and gingivitis and things in the mouth. Of course, when you go further into this detail, the case might reach even reflux or GERD, okay? And it would be great if you, as a dentist, would discover this. And I never forget this female patient who came to me, and she said that she was complaining of stomach disturbance and insomnia. She could not, difficulty to go to sleep. When I examined her mouth, I found a very enlarged uvula, and she had enlarged turbinates also that I found on the panoramic radiograph. She went to the ENT specialist and had this corrected, and now she's better with sleeping, she is better with her stomach and everything. Of course, please look at the nasal space, and you can see the radio opacities enlarged with those turbinates sticking into the nasal septum. The surprise is that this panoramic radiograph belongs to a young girl who is now 22 years old. This means that the work was done probably when she was 18 or something like this. Let's evaluate and criticize the work done. This case had many porcine-fused to metal restorations. As you can see, lots of posts and cores. From my point of view, you don't need those posts and cores that much. I am most of the time against using posts and cores because if you are drilling to do a post, then you are causing micro fractures, micro cracks in the tooth without even knowing this. And this is all in a static situation. Then when you are placing your post, you are causing more pressure inside the tooth, which is dead and extremely hard. It's not as elastic as it used to be when it was alive. That's number one. And then you build the core, or you have a core ready. If you build the core with composite, which is very nice in color, tooth colored, and then you start preparing, probably many dentists will forget to do what's called the ferrule design or concept of using 2 millimeters of the tooth structure. This way, you would depend on the core for holding the crown. Then this is all in a static situation. Whenever the patient starts using his crowns, lots of stresses that would cause probably longitudinal fractures after some time, and we as clinicians, we see those cases all the time. I know that what I'm saying is against lots of people, because as a good dentist, you think highly of yourself when you're doing a good post and core restoration. However, after some years, if you really follow up your cases, you would find lots of problems caused by the posts and cores. The other thing, when you look at this case and you see lots of single crowns, especially the upper anterior areas, for example, see how many contact areas is there. Of course, I have this question mark about contact areas that are done by lab technicians who said that those contact areas are right, in the right position or even the right dimensions. I think that splinting, and let's say splinting of the upper, central, lateral, cuspid together with a 3-unit bridge on the other side, splinting is a key for success. For example, if you splint, then you are distributing the load in a better way. You don't need those post and core, and work would be easier and even last longer. Let's go into the lower anterior areas where are the tiniest teeth in the mouth, and you can see the longitudinal fracture causing radiolucency in the lower right lateral incisor area. And this is very normal to happen with restorations like this. The reason for this patient to come to me with the mandibular right implant placed in the place of the first molar, and where the crown used to move, and at the end the crown was lost with the abutment, the implant abutment. And I will explain what we did with this special case. On the lower left side, or the mandibular left side, you can see 2 implants with 2 single crowns. Again, we are increasing the number of contact areas, and from my point of view, if we splinted those 2 crowns, it would have been a better situation. This is the case, generally speaking, and you can see the implant that needed an abutment or needed restoration in the mandibular right area. Here, I was able to know the implant type by asking the patient. The clinician who did the work lived in abroad, and I called her, and she was very nice. She said she gave me the type of the implant. I was able to buy the abutment. Going back to my way of thinking, what I did was remove the single crowns done, put the implant abutment in place and then put a temporary 4-unit bridge and make impressions and everything. People here would talk about combining implants with natural dentition. Of course, everybody knows that there are two schools of thinking. From my side, I really believe in combining implants and natural teeth in one condition, that periodontally speaking, the natural teeth are okay. My philosophy here is that we combine proprioception with implants, because as everybody knows, there is almost no proprioception with implants because it's also integrated, it's directly connected to bone. So if we combine natural teeth to implants, then we are including proprioception to the whole area, which controls the chewing efficiency and strength or bite force on restorations like this. Then final bridge was fabricated, and in order to place or finally cement this, I would love for you guys to use my technique published in the Journal of Prosthetic Dentistry 1995. And this clinical tip was really something that I've been using since that time, and I advise you all to use it. You place dental floss between the crowns beforehand, and then you fill the bridge with cement and let the patient bite with the floss hanging like this, and then you hold each piece of floss and move it buccolingually and in a rotatory movement, then pull it buccally, then you can get rid of the excess cement. Here's the final restoration in place, and this was done like a couple of years ago, and the patient had no problem with it. A case like this, please watch. No one abutment was really placed in a correct way. However, looking intraorally, the dentist, when he was placing the abutments, he felt satisfied because he was using lots of force to place the abutments and everything was fine, but he really forgot to do a post-operative radiograph. And if this special situation, if the crowns were not splinted, definitely a screw fracture would have happened. In a case like this, if you are doing an implant case and you have no attached gingiva, no way that this part would ever heal. You must find enough attached gingiva. In the Middle East, at the beginning of working with implants, the lab technicians did not know what was happening. They thought that every single implant replaces a tooth. Kept on explaining this to my technician. However, he did not understand till I made him repeat the case and do it this way. It was very nice in the patient's mouth. What a wonderful world implants can give you, only if you know when and how to use it. I am inviting you to really see what I've been doing for the last few years with patients here at my office, because I really reached a simple way of thinking about implants that is giving me almost 100% success. Thank you very, very, very much.